Okay. Well, good afternoon, everyone. I'm Dr. Summers. This is the little slide that they require up there, so you've got an event ID and how to get the CME and all of that. If you need that again at the end, just let me know. And the topic today is men's health. Let's see if I can get rid of that little got it there. Okay. Topic today is men's health, which should be a fairly quick topic since it only covers about half the population. Disclosure, basically I have no conflicts of interest, no promotional agreements with anyone or anything. However, I am male. So one small conflict of interest. This is also rated R. There are some things that we'll talk about that kind of get it a little R rating. Just as an aside, when I was setting this up, I got an email from the staff from the department with instructions on how to put video into the presentation. I said, the topic is men's health. I like to keep my job. I'm not putting any video in it. All right. Main areas we're going to talk about: statistics, interventions, and then sexual health. Some statistics. Men are bad actors. You know, we've got lots of bad habits. We're just, bad folks. Percentage with an appropriate level of physical activity is just about half. So, half the folks don't. Percentage of men with 5 or more drinks on at least one occasion in the past year, 30.9%. So 30% drink too much, don't have enough activity, and the percentage of men over 18 who smoke, 21%. So 1 in 5. Bad habits. We're also fat, hypertensive, and poor. The percentage of men over 20 who are obese, 34%. So actually over a third of men over the age of 20 are obese. Percentage of men over 20 with hypertension, right about the same numbers. There may be a correlation there. And these stats are from the CDC. And the percentage of men who are under 65 who are uninsured, 18. Whether that is changing with Obamacare, and that is yet to be seen, but roughly 18% of folks, of males under the age of 65 are uninsured. Over 65, Medicare kicks in. So, with all those wonderful habits and fat and hypertensive and all of that, how do we keep these creatures alive? Leading causes of death for males: heart disease, cancer, and accidents. So, talking about heart disease. Okay, male sex is a non-modifiable risk factor. Believe it or not, there have been studies. They were thankfully small studies that showed that castration does not actually affect the likelihood of developing heart disease. The 2-to-1 male to female ratio for coronary disease extends across cultures. So it's not just cultural influences, not just crazy Americans who do crazy things who are doing this. So what you need to do is to focus on the modifiable risks. That percentage of folks that are smoking, for example. Cancer. Basically, that second leading cause of death, I've got listed here the top cancers for males, with a risk of acquiring and risk of death. So 1 in 13 males will develop lung cancer in their life, with a 1 in 15 chance of dying. So we're not actually very good at picking it up early enough to make a difference. Colon, we're a little better at. We can screen better for colon cancer. 1 in 21 chance of getting colon cancer, 1 in 49 chance of dying of colon cancer. Prostate, incredibly common. 1 in 7 chance of acquiring prostate cancer for every male in this room. 1 in 7 chance of developing prostate cancer during your lifetime. 1 in 38 chance of dying from it. So if you do the math, the quick math, that says that 1 in 5 men who develop prostate cancer actually die of it. The other 4 will die of other things. Bladder cancer, also pretty common, 1 in 26 chance of getting it with a 1 in 110 chance of dying from it. Bladder cancer tends to be less aggressive, fewer fatalities. Pancreas, we're not very good at detecting or treating. 1 in 66 chance of getting pancreatic cancer and 74 of dying from it. And melanoma, yeah, we do pick those up a little better. 1 in 39 chance of getting melanoma, and 1 in 233 of dying from it. So basically, if you get melanoma, you have a 1 in 6 chance of actually dying from it. So, cancer prevention, again, looking at your modifiable risk factors. Stopping smoking. This is something we need to continue to emphasize with our patients. Not only does it reduce their risk of developing heart disease, reduces their risk of developing cancer. Colonoscopies, or the immunofluorescent, the IFOB, as an alternative to colonoscopies for those who just won't do the colonoscopies. That's a lot better than the old fecal occult blood testing that we used to do. So, but doing these screens so that you can make interventions, especially on those things that we have successful interventions. For prostate, the risk factors of race, age, family history, BRCA genes, all non-modifiable. Obesity, high saturated fat diet, those are things that you can emphasize. So, and we'll talk about PSA in a little more detail later on. Okay, so last words. What are the last words a male under the age of 45 says before he dies?
Hey, what's this?
Accidents. Basically violent death is hugely, a huge percentage of male deaths. It is the leading cause of death for males under the age of 45. Boys are twice as likely to die of play-related accidents or falling out of windows than girls. 3 to 4 times more likely to have spinal cord injuries. Who here's a Game of Thrones fan? Yeah, Bran. Okay. So, falls out of the window or gets pushed out of the window, lands on his back and is paralyzed and develops some other interesting capabilities, but most kids don't. Up to age 44, accidents are the leading cause of male death. 5 times more likely to die from drowning. And a lot of what you see around here is that's then associated with alcohol abuse or other intoxicants, where folks will decide that, oh yeah, it's late at night, got a little buzz going, let's swim across Boone Lake. And they get, partway out, may get a little disoriented on where the nearest shoreline is, get tired, and drown. And this happens every year, that at least at one of the lakes around here, there'll be drownings. So, what can we do to try to intervene on that? Don't go swimming alone. There's the whole, there've been public service announcements for decades about folks not swimming alone. And then reminding folks that, if they're going to use their favorite intoxicant, they probably should not be doing hazardous things, like driving, like swimming. Violence. 4 out of 5 homicide victims are men. Sometimes think that, spousal abuse issues and that sort of thing. Actually, 4 out of 5 homicide victims are men. It's the 3rd leading cause of death in ages 1 to 4. 2nd leading cause of death, ages 15 to 19. And the 3rd again, from 20 to 34. It's the 4th leading cause of death in African American males, and the 1st in the age group 15 to 24. So these are violent things. This isn't just, accidents. This isn't falling out of a tree. This is violence. This is people killing people. So interventions. With the safety things, seat belts. Ask about them. Ask to make sure the folks are doing that. And yeah, there are a few folks that are actually harmed by the seat belts, but far and away, people benefit by wearing seat belts. So ask about them. Make sure that they are actually wearing them, that they're not thinking it's uncool or something on that order. Drugs and alcohol causes too many disinhibitions. Folks then start to do things that they wouldn't do otherwise. Driving while intoxicated, and how many things you read in the paper about DWI or DUI accidents and that. The drugs, the drownings, all of these sorts of things. Basically safety goes to the wind when you're under the influence. Gun safety. Something that, guns are pretty popular in this area. They're actually pretty popular in the United States, but they're especially popular in this area. And, whether you agree with that or not, to make sure that folks are using them safely, that they keep them locked away, especially in cabinets away from kids, making sure that, and that they're not reaching for a gun when they're under the influence of drugs or alcohol. And then safe sex. Proper selection, barrier methods. So question, leading causes of death in men all ages are accidents, heart disease, and cancer. Number 1. Okay, special topics. Erectile dysfunction and safe sex. When you have a patient who presents with erectile dysfunction, that's probably the most common men's health issue that you'll run into in the office. Consider the causes and try to work with those causes first before just saying, okay, here, take a Viagra. Consider the causes. Stress. There's all kinds of stories about surgeons having erectile dysfunction issues the night before a big operation, that they're worried about the patient. Stability of the relationship. Things are not going well, then you're more likely to run into erectile dysfunction. All sexual dysfunction tends to increase with that. Medical conditions. Common ones, hypertension, diabetes, certainly have their effects on erectile function. Trying to make sure that you've got blood pressure under good control, that their diabetes is well controlled, and this is also looking at it long term because the neuropathy in that can occur as well as vascular changes with diabetes. Medications. Are you giving them something that may have a negative effect on their ability to function? Especially the antihypertensives are notorious, But within the antihypertensives, there's some that are more likely to cause problems than others. Beta blockers, for example, will tend to have more problems with erectile dysfunction than say, diuretics or ACE inhibitors. Hormone levels. You can get into safety issues about treating hypogonadism, but that's something that should be screened for when you have a patient who presents with erectile dysfunction. So, depression, obviously mood changes. We've got many depression screening tools within Allscripts that can help you with doing that screen. Alcohol, alcohol seems to increase desire but decrease performance. So, obesity has its effects on the hormones and that, but also on physical functioning, patient self-image, and smoking. Again, you can push on the smoking issue again with the patient who you're trying to get their cancer risk and their coronary risk down. This is one of the things you can say, hey, smoking affects your erectile dysfunction. If you want to continue to function, you need to get rid of the cigarettes for that reason. They may not buy your cancer argument, they may not buy your coronary argument, but when you tell them that they're not going to be able to perform, now they pay attention. Okay, treatments. There's a whole range of treatments available for erectile dysfunction, such that basically the urologist will say that everyone can have their erectile dysfunction treated. There's always something that can be done. Most extreme, implants. The implants can come as just an implanted firm body, or many times now they tend to use something that is push-button inflatable, basically where fluid will come from a reservoir to cause the erection, and then can press the button again, which is often located in the inner thigh, to then get it to go back down. Pumps, allosterone powers. Basically, the vacuum pumps, essentially the way they work is that you put the pump over the shaft of the penis, pump to increase, basically reduces the pressure inside the tube, increases blood flow to the penis. When the penis has enough blood in it, enough engorgement that it's erect, then you put a ring around the base of the penis to keep the blood there, and good to go. Alprostadil. Alprostadil was probably the most popular erectile dysfunction treatment prior to the Viagra and related medications, the Pde5s. Alprostadil comes in two forms. One is an injection, where you inject it into the base of the penis and it causes an erection. That has a variable acceptability by patients. And then there's a urethral suppository. And the patients that I've used, where I've used this with the urethral suppository, they call it muzzle loading. But basically, it causes an erection to occur. Then there's the Pde5 inhibitors, the class Viagra, Levitra, Cialis. This is what people often will go to first. They're expensive, but they work the majority of the time. Viagra is available 3 strengths. You start low. Issues are largely with the side effects, which you can have vision loss, hearing loss. Those are uncommon, but they do occur, so you have to warn the patient about it. The more common side effects is what's called a Viagra hangover, where the person will have a little bit of nausea, a little headache, and just not feel a little out of sorts the next morning. So kind of like a hangover. So there's that. Another thing is, again, something to warn folks about is the blue tinging of the vision. It's not a loss of vision, but it's just like looking through a blue filter. Issue for airline pilots, they're not allowed to use Viagra for a period before they fly because they need to be able to look at lights and tell what color they are. And also if certain occupations where they need to like match colors and that. Levitra was the second to come out. Its main claim to fame is that it's very much like Viagra but has a lower incidence of the side effects. And then Cialis was the most recent one, and that has different kinetics. Not quite as high a peak, but a much longer duration of action, where the Viagra and the Levitra are typically in the 6 to 12 hour range. The Cialis is more like about 36 hours for the duration of action. So, which is why in Europe it's sometimes referred to as the weekender. And I'm just going to mention for more historical purposes, but someone who doesn't want to take any medications for it, you can recommend this. There's a Mexican root called yohimbine. It's sold in many of the herbal places. And most of the studies that have looked at it have shown that it doesn't really work, but there have been a few studies that have suggested it may help some, and so that it's another option for folks who have a problem with the other options here. Questions on any of that so far? Okay. So a 60-year-old male had transient blindness from sildenafil. He still wants something for erectile dysfunction. You would recommend? Anyone? C, alprostadil, right? Because that's not a Pde5, and probably not going to successfully recommend D. So the alprostadil, that's the injectable or the muzzle loading approach, and so that's going to be your best option with someone who has had one of the more serious side effects to the Pde5 inhibitors. Just a word about about generic Viagra. Basically, you'll occasionally hear patients mention something about it and say that they've heard there's a generic Viagra out there that's a lot less expensive, or that they might be able to get it from Canada or things like that. It's true. Sildenafil citrate is available generically in a 20 milligram tablet, released for treatment of pulmonary hypertension. People can save a lot of money by getting the generic sildenafil citrate tablets at the 20 milligram strength. It's admittedly a lower strength than what the Viagra typically does, but it's the same medication. Now, Walgreens won't sell it that way, because they feel that you shouldn't be using anything for an off-label use. I think there's actually probably more financial reasons for them not doing that than anything else. But Walgreens will not sell it. Your mom and pop pharmacies will. So in Kingsport, the Max Medicine Mart, Caves, all of those, they'll get the 20 milligram sildenafils. And so you can treat your patient. You just tell them, okay, take 2.5 of these, that's 50 milligrams, that's the same as one of the medium strength Viagras. So it is an option for your patients. Explain to them what you're doing. You are using it off-label, kinda, but it's the same medication. Okay, so the safe sex issues. Okay, first, choosing wisely, because everything other than abstinence has a failure rate. Condoms reduce the risk significantly, at least reducing it 90%. But the statistics that I've heard is unprotected sex with a with an HIV positive person has a 1 in 600 chance of transmitting HIV. And that with a condom, it's 1 in 6,000. So it's lower, but it's not zero. So choose wisely. Testing, and this is not just for the HIV, but also, for hepatitis C and some of these other diseases, and the human papillomavirus, all of that. There was a bus sign campaign in New York. That's be positive, you are negative. And they had that on the sides of buses all through New York. And so people ask, it's like, be positive, you are negative. And to suggest everyone should screen for HIV. So those public health things are useful. And then barriers, which we talked about, condoms are the main issue. Okay, word about PSA. This is, an area of controversy. The American Cancer Society and the AUA, the American Urological Association, are pretty much in alignment with what I'm going to show you here. The U.S. Preventive Services Task Force, the USPSTF, says just say no. It's a do not do. However, I looked at the USPSTF website this morning, and they say that this is under review again. It is being, under consideration. So the recommendations are up for review. They may change from there. But American Cancer Society and the AUA suggest they've got like 5 statements here covering different situations. The panel recommends against screening in men under the age of 40. Prevalence is so low, not worth it. Next panel does not recommend routine screening in men between 40 and 54 at average risk. However, for men who are under 55 and at higher risk, such as positive family history or being African American, then the decisions regarding prostate cancer screening should be individualized. In other words, talk to the patient. Talk to them about the pros and cons that go along with the testing. If your test comes back a little elevated, are you going to be worried about it, or are you going to be comfortable with watching that? Are you going to get a biopsy? Problems with the biopsy is that there are complications. Complication rate is actually somewhat high for a basic biopsy of the prostate. Issues with infections, the complications often require hospitalization. So, and it's not the most comfortable thing. It's a transrectal needle biopsy. Next, for men ages 55 to 69, they say that the decision to undergo PSA screening involves weighing the benefits of preventing prostate cancer mortality, remembering the difference between incidence and mortality that we saw earlier. 1 in 7 men will get prostate cancer, and currently 1 in, I think it was 38 men will die. For this reason, the panel strongly recommends shared decision-making for men age 55 to 69 that are considering the PSA screening based on the man's values and preferences. So, not something to just include in the panel when you're doing an annual physical on the patient. You want to have a discussion with them, tell them the pros, tell them the cons. The greatest benefit in screening appears to be in folks in that age group. To reduce the risk, the harms of screening, routine screening interval of 2 years or more may be preferred over the annual screening. And that's especially in patients who have a PSA less than 2. the American Cancer Society actually goes goes with that, saying that if it's less than 2, then go every 2 years for the PSA screening. And then don't recommend in men over 70 or any man with a less than 10 to 15 year life expectancy. And ACS has 10 years. So, but AUA also adds that some men over 70 who are in excellent health may still benefit from prostate cancer screening. But that 10-year cutoff is common in all the screening sorts of things. That's also the cutoff with colonoscopies. Someone who has a less than 10-year life expectancy, they've graduated from doing their colonoscopies. Pat them on the back. What about a better PSA? Free PSA is another way of looking at PSA. Looking at, basically, it's the free and total, and then you get a percentage. Percent free, higher percent frees are actually better. Lower percent frees are worse, increasing your risk. If you're between 50 and 59 and you have a high PSA, free PSA of greater than 25%, you're in the lowest category at 9% risk of having prostate cancer. Again, thinking about that, it's around 15% all comers, because 1 in 7. So that's 15% all comers. 60 to 69, and you can see it goes up, 12 to 15 if you're in that high percentage group. And if someone is 70 and they have a free PSA of less than 10%, then they have a very high risk of actually having prostate cancer. So, it's another way of looking at it. More information, no direct guidelines, unfortunately. We haven't gotten there. Because the other part of this is that we don't know that any of the screenings have never been actually shown to extend life expectancy. Okay, so we'll end with this. Modifiable risk factors of prostate cancer. Item number 3 on the list to the right. Won't really talk about penis transplants, but item number 3 there. Best evidence yet, ejaculation reduces prostate cancer risk. Without further comment. Any questions?
With the free PSA testing,
Yeah.
is that being used as a next step if the rate? I know there's no guidelines, but would you do that, for instance, if the total PSA was elevated and you're trying to avoid a biopsy or to try to guide decision for biopsy, or is it used on the initial onset when you go to the lab, or how is that fit into the equation?
Usually uses second line. If you're going to be doing a PSA on a patient, then you usually just do the total PSA. If the PSA is elevated, or if you see that it is rising, if you're doing serial PSAs, there's something called PSA velocity, how much it goes up per year. If that is greater than 0.75, then that's an abnormal PSA velocity, and that would then trigger getting the percent free. And and so that's where that usually comes in. If you think about it, those do go hand in hand. Someone who's got a PSA that's rising a little faster than normal, is there inflammation? Because that's probably the biggest cause of false positive PSAs is inflammatory process, either acute or more commonly chronic prostatitis. So if they have the elevations and you get the free PSA and it comes back 30, you can rest a little easy and continue to follow those numbers as opposed to needing to stick a needle in. Other questions?
In gender studies, you had mentioned that there is no difference in castration with the risk factor.
Right. Well, transgender, you don't implant a prostate. So there's no issue there as far as prostate cancer. And if you go transgender the other way, you know, from male to female, that's what you were asking. Okay. Sorry.
I was wondering, how do you not have a prostate? Thank you.
I don't know if they remove the prostate as when they're doing the transgender. Do they do not? Okay, because I'm thinking about when they form the vagina. Okay, so they don't. Yeah, I know of no studies. So I would assume that there would still be some risk associated.
Guidelines say we continue routine screening for all women after transgender.
In which gender?
Right.
Like original gender or the?
Any original gender.
Like two different screenings?
Yeah. So the guidelines are to continue with the with the routine screenings, but the guidelines for PSA are then, you know, the screening for prostate cancer remain in flux.
I'm just thinking this is going to be an upcoming topic, so we should
Yeah. Indeed. You know, I don't know of any studies. I think that there's probably going to be, you know, that's something that needs to be looked at. Because there's less testosterone, they're probably at lower risk. Yeah. Other questions? No? Okay, then get back to work. Thanks.
Good approach. But you've taken this on the road, haven't you? You've done this.
I did this last year.
I was here. I remember being